Hello, everyone, and welcome back to another episode of Arthritis at Home. My name is Ellen, and I'm the program's coordinator. Today, I'm joined by Deniz, who has a background in physiotherapy and is an associate professor at a university in Turkey. He completed his PhD in 2017, focusing on the effects of water-based exercise in juvenile idiopathic arthritis, and now he continues on that trajectory. He was appointed as the president of the health professions in rheumatology in Turkey, and he is also an affiliate scientist of Arthrite-recherche Canada as of this past June. Deniz, welcome to Arthritis at Home.
Hello, Ellen. It's good to be here.
Deniz, can you tell us about yourself and how you're involved in rheumatology?
Thank you very much for inviting me, Ellen, first of all. So I'm a physio, as you mentioned. I graduated in 2013, and when I graduated first, as most of the physios, I started to work with the neurology. So for the first 2 years of my career, I worked with the neurologic patients. Then I decided that I need a change in my career, so I look for the other options. And in my family, there are some, for example, my uncle is an axial spondyloarthritis patient. Also, my grandmother has the GUT. So I decided that rheumatology can be a really good path for me to improve or to work on it. Then for my PhD, I try to look for an opportunity who is working with the rheumatology. Then I find a position where a professor is working with the juvenile idiopathic arthritis, and I was accepted to that PhD position, and my career on the rheumatology track started like that. And thankfully, I'm really happy to be in this track, and I really love the the progress the uh, physios can do for the patients with the rheumatism. So it's a perfect opportunity for any physio who wants to see the results and the satisfy a professional satisfaction with his work. So it's an amazing field of our profession for to uh, work on it. And from, as you mentioned, from 2014, I'm working with both pediatric and adult rheumatic diseases. During my PhD, I focused on mostly juvenile idiopathic arthritis, but after my PhD, when I started to build up my own lab, we are now doing work with both with pediatric and adult patients with various rheumatic diseases. So we have some diseases very specific to Mediterranean area, some of the autoinflammatory diseases which are not so common in Canada. And on the other hand, we are also working with the most most types of the arthritis that you are seeing in the Canada as well. So it's a very broad um, types of topics that we are working right now. And as you mentioned, then we are working on the different exercise approaches, different rehabilitation approaches for those patients. And we are trying to improve their quality of life and other aspects of their negative consequences of their diseases.
Like you said, rheumatology is incredibly broad, right? And it is so progressive. I'm sure you've seen so much movement in the field, even within the last 5 years, as
That's right.
we get better at biologics. We get better at pairing biologics with different physiotherapy modalities, right? And physiotherapy, as it stands, is still underutilized in so many ways for not only the management, but perhaps even the treatment. Like nobody has ever looked at an exercise regime to treat, actually, right? So much progress. You are at the cutting edge or the leading this progress.
Deniz, actually, it's really interesting because after the biologics, many people here in Turkey, for example, thinks about that, okay, the physiotherapy is finished for the rheumatology, but it just started, because now there are some projects and there are some studies showing that the exercise helps to the patients who are under the biologics. So if you are taking your biologics and you're doing your physio, then it's the best combination for you. So we are still around, and physio is perfect for all the rheumatic diseases. But all the rheumatic diseases, not just for the arthritis, but all types of rheumatic diseases.
Absolutely. That is well said. Truly all types, and there's so much potential there. I think it's just untapped. We don't know. We really don't.
Yeah.
So Deniz, could you tell us about the types of juvenile idiopathic arthritis and perhaps how rare they are?
So juvenile idiopathic arthritis is an umbrella term. So there are 7 different types of diseases which are very distinct to each other under that term. So some of them are affecting the lower extremities, and some of them are affecting mostly the fingers and the hands. Some of them has more systematic effects. So as I mentioned, there are 7 different types, and these types are the prevalence for those types are changing from country to country. For example, for the Turkey, most common type is enthesitis-related arthritis, which is you can think about an axial spondyloarthritis for the juvenile form. But for the Scandinavian countries, it's mostly the oligoarticular or the polyarticular arthritis, which affects the fingers and the upper extremities. So it's changed from country to country, or even inside a country, it changed from region to region. So, but we can say that they're kind of rare. Some subtypes, for example, the systemic, thankfully, because it's the most severe form. So systemic juvenile idiopathic arthritis, for example, is a little bit rarer than the others. And if uh, and the management of all those subtypes are different from each other, because it's logic, if there is a lower extremity involvement, then you will focus on the lower extremity, and if there is an upper extremity involvement, maybe you will send them to the occupational therapy first, and the management will be different for each subtype. But in our clinic and in our work, we are always thinking as the JIA like one disease, a single disease, but it's not the right approach. Now, all the pediatric rheumatology is trying to change their approach for that, because there are 7 different diseases, just the name under a single name.
No, you've made a very good point. Number one, we assume, the majority of rheumatic conditions being, like you said, a bit rare, right? But understanding there is an epidemiological or geographic difference in a lot of these conditions. So that gets you to start thinking, why is there higher prevalence in certain countries? And the other thing being that we use terms to describe JIA or juvenile idiopathic arthritis, when it would be more correct to simply use each of the 7 names that represents a completely, right, different condition that has different effects, that requires different treatments, right, different understanding, different level of expertise for management. And I like that movement as we're getting more nuanced with our language, right? And that field is working towards that, because I myself know, I know what JIA is. I don't know what each of these systemic versus the upper extremity and the lower extremity. So thank you for sharing that with our audience. And Deniz,
Also, yeah, also it's really important to know the differences and which are specific to which region of the world, because as a country in Canada, as a multinational country where you are expecting, you are welcoming many people from different parts of the world, it's really nice to know, to have a basic knowledge about the background of the disease. Because if you have for example, a Turkish patient, so we are not just talking about the juvenile idiopathic arthritis, but maybe another disease where, as I mentioned, the one related to Mediterranean area. So, for example, we have a Mediterranean fever. So the main symptom is the stomachache. And most of those patients, if you are not very familiar with that, are going to do appendectomy. So they are removing the appendicitis. I don't know if I'm pronouncing it right, but they are going unnecessary surgery because they are just thinking that it's mimicking another disease. So it's really important to know some regions have some specific diseases. So it's and it can be not very common where you are living. For example, in our example of the Canada.
Now with that, Deniz, will you share with me a little bit more about your multi-site project? This is an international, if I'm correct, a cohort study looking at juvenile idiopathic arthritis, where I'll correct myself in saying the many different types of juvenile idiopathic arthritis. Could you share a little bit more with us?
Yeah, absolutely. So as I mentioned, there are 7 different types of the juvenile idiopathic arthritis, and they are presenting very differently from each other. And due to this fact, we are expecting the 24-hour movement patterns will be different between the subtypes. Also, as I mentioned, the different parts of the world have the different parts of the cultural things and the social interactions and anything that shapes our 24-hour movement. 24-hour movement is an interesting concept for me because before coming to Canada, before coming to Arthritis-Recherche Canada, we are always looking for the physical activity or sleep or the sedentary behavior, but individually. We never think about to combine them as a concept for the 24-hour. That's really a correct way of the approaching to do behavior. So after I came to the Arthritis-Recherche Canada, I had the chance to learn this concept. Then I wanted to combine my research with that new concept. So we are already looking for the physical activity. Why don't we go to the further and looking for the whole movement pattern during the day? And the juvenile idiopathic arthritis is a perfect opportunity for that, because we are always accepting this disease as a single disease, but it's not a single disease. So we need to show the differences between the subtypes, because if it's logical, so if you are mostly involved with the lower extremities, so your physical activity would be more affected than the upper extremities. Yeah, it can be the vice versa, but most of the times it can be there will be a difference between the subtypes. So this is the main question. Then also we will consider about the differences between the countries and the regions of the different of parts of the world. For example, the Scandinavians are very active, but the Mediterraneans are not that active. Also, we want to see how it will be affected in a multicultural country like in Canada. And then we gathered 7 different countries and make a collaboration to both having more patients with the subtypes. As I mentioned, some subtypes are rarer than the others. For example, if you want to measure the physical activity or the sleep patterns for the systematic juvenile idiopathic arthritis, at the end of the year, maybe you will have 10 or 15 patients if you are working only from the one center. But if you are making a collaboration with the different countries and different parts of different clinics, then you will have more patients. So it will be a great opportunity to increase the number of the patients to be involved. So that's why we started a collaboration like that. And now we are just trying to get some funding, because the research is very different for each country. For example, if you want to make a research in Scandinavia, you really need to secure some funds to reimburse your time. We are not working like that in Turkey. For example, if you ask me to make a research, then I can find some time for my research and I may not need some reimbursement. So it's something like a culture for the researching is also different from country to country. So that's why now we are having some difficulties between the countries, but we are trying to figure out and find a way to work together in a very soon, I assume.
Very exciting, number one, that you are gathering so many different countries, because that allows you to understand context, right? Because context, which is your environment, your upbringing, different cultural aspects may indicate as well as influence the type of arthritis you have and how you manage it, right? Like you said, in Scandinavian countries are really active. Also, then you have the complexity of looking at 7 different types of arthritis across 7 different countries. So like what a beautiful, but also just like an intricate way to study 24 hours, right? So not just exercise, but where exercise fits in terms of sedentary time, in terms of sleep, right? Within that full cycle of your day. So it seems like it's going to be a ton of work, but we're very excited for you, Deniz, as you approach on this journey, and we want you to keep us updated.
Of course. Also, it's not just the culture, but before starting this interview, I mentioned you about how hot here is. So the weather, the money, for example, the facilities, everything's really shapes your 24-hour movement patterns, also your daily living. So it's really interesting to see those differences as well, because most of the times many countries are using the data from the United States or Canada or the Scandinavian countries, but we don't have our own data. And it's pity, because okay, we are saying that, for example, it's even in for the epidemiological studies. So juvenile idiopathic arthritis is 1 in a million, I'm just saying, in the United States. But it's not the truth for the Turkey or the other countries. So we need our own research. We need to compare the countries. We need to make those efforts to see what are differences. So that's why I'm really excited about that project. It's not the first, of course, collaboration between the countries, but for the pediatric rheumatology, especially if we are talking about the 24-hour movement patterns, it will be the first. So it's a great opportunity to see how different we are from each other and to understand that.
Absolutely. That is a foundational first step to understand, like, what can we improve on? What are certain countries doing that are allowing them, right, a more movement-centered 24-hour guidelines, right, to understand the differences and thus be able to build on each other's, right, strengths.
Yeah, also it's a good opportunity to see if the Norway is doing right, then try to be a Norway, try to get the Norway's way. Or if Turkey is doing wrong, don't do that mistake again. So learn from your mistakes. It's a great opportunity to see the good examples, to prevent from the bad examples. Yeah.
So exciting. What a beautiful research design. And Deniz, we all wish you luck because we all want to know what you learn from these projects. And we hope everything's sorted out, right? As you move forward, these cross collaborations across countries are not super fun on the administration side. They're a lot of work. So Deniz, thank you for your contribution to science. Thank you for your contribution to arthritis. And we are so grateful to have you on our program.
That's my pleasure. Thank you very much.
With that, everyone, have a great rest of your week, and we'll hope to see you at the next Arthritis Home. Goodbye for now.